There are other classes of antiarrhythmic agents besides digoxin, and Chapter 45 discusses these. Antiarrhythmics block the sodium channels, and all are classed by the way they block these channels. Antiarrhythmic class 3 drugs include amiodarone, which blocks potassium channels to slow the movement of potassium out of the cell. They prolong repolarization. In peripheral smooth muscle, it decreases peripheral resistance, which leads to vasodilation. Given IV, it is the ACLS drug of choice to treat life-threatening ventricular arrhythmias, and orally amiodarone is given to treat supraventricular tachyarrhythmias. The adverse effects are due to the changes created as potassium channels are blocked: nausea and vomiting, GI distress, dizziness, fatigue, malaise. Respiratory, the drug can create a situation called ARDS, which is acute respiratory distress syndrome, and can lead to hepatotoxicity in the GI tract. The drug has a very long half-life, so you must use caution when changing from the IV to the oral dose to avoid toxicity. Therefore, the IV dose is going to stay in the system for a very long time, so you may need to delay the start of the oral dose to allow for that half-life being very long so that you're not giving the patient too much drug. There are class 4 antiarrhythmics, and you will note that in your textbook, diltiazem, which is also classed as a calcium channel blocker, is listed as a class 4 antiarrhythmic. Anti-anginal agents are drugs that are used to treat angina. And angina occurs when the heart muscle has a lack of oxygen, which is caused by a blockage of the blood flow to the heart muscle itself. It can be categorized as stable, where there is no change to the heart muscle because the blockage is minor and some blood gets through, or unstable, when ischemia can cause chest pain, and that can occur even when the patient is at rest. If the coronary vessels become completely blocked, the muscle becomes ischemic, necrotic, and the patient has a myocardial infarction. Anti-anginal drugs are prescribed to treat angina and hopefully avoid progression of ischemia to tissue death and myocardial infarction. An example are the nitrates, nitroglycerin. Its action is to improve blood delivery to the cardiac muscle by relaxing and dilating the veins, arteries, and capillaries, which dilate the blood vessels to increase blood supply and oxygen supply to the heart muscle. It decreases the work of the heart by decreasing the oxygen demand and decreasing preload and afterload. Common adverse effects include headache and dizziness and hypotension, particularly if given IV. They can also cause tachycardia, and if given in a paste or spray, can cause a skin rash. The drug can be administered sublingually, PO, IV, and as a spray. Teaching is very important for these patients. You need to teach them that if they're taking the sublingual pill, that they need to take a sip of water first to moisten their membranes, which decreases the time required for the drug to dissolve. The patient can repeat that medication 3 times every 5 minutes, so you can take it 3 times every 5 minutes apart, and if they're still experiencing chest pain, they must call 911 for assistance. Also with sublingual, you can tell that the drug is potent if it fizzles and burns when you place it on the mucosa of the mouth, and that is important because you'll know whether it's effective. Patients should not swallow these pills, and they should alternate sides of the tongue when administering to avoid the skin rash. Storage is extremely important for the pills. They need to be kept in the same bottle, which is typically a dark colored bottle to protect the drug from light, and they should store it in a cool, dark place. Because of the short life of the drug may need to be changed out, regardless of how many pills are still left in the bottle after 6 months to a year. Patients should check with the pharmacy about the expiration date so they know when to exchange their drugs. The transdermal patches should be stored safely if in tubes with paper in order to prevent mixing it up with a hand cream. So you would not want someone else in the household to grab that tube and think it's hand cream. So you need to teach them to store it safely. As well, you need to review the patch and ointment application information in your textbook back in the appendix. Be sure that as a nurse, you are wearing gloves when you administer the patch or the paste to the patient to keep from getting and absorbing the drug into your own system. Chapter 47 talks about lipid-lowering agents. Hyperlipidemia is an increase in the lipid levels of the blood. For individuals with high serum lipid levels, there is an increased risk of coronary artery disease, and drugs that treat this condition are called anti-hyperlipidemic agents. Bile acids contain high levels of cholesterol and precipitate the fat digestion process. They are released from the gallbladder in response to the presence of fat in the small intestine. Lipoproteins are produced in the liver and are either low density, LDLs, or high density, HDLs. The LDLs enter circulation as tightly packed cholesterol, triglycerides, and lipids. The HDLs are loosely packed and used for energy and serve as a protective measure in the body. HDL levels increase during exercise and in response to the presence of estrogen. When we have increased levels of cholesterol, triglycerides, and lipids in the blood, the risk of developing plaques which narrow the walls of the coronary arteries increases. Drugs that help lower cholesterol are divided into the bile acid sequestrants, the HMG-CoA inhibitors, or the statins, and we will discuss those. Again, cholestyramine is the bile acid sequestrant prototype that we're using. It is used to treat patients who have increased total cholesterol and increased LDL, that tightly bound cholesterol lipoprotein. The side effects of these drugs include cramps and nausea, flatulence, and constipation. Electrolyte-wise, they decrease the absorption of vitamin K and should not be taken with other drugs because of the absorption problems. They can increase bleeding time, so when taken along with anticoagulants, you may have extra bleeding, your patient may have extra bleeding. And musculoskeletal, some patients complain of muscle aches and pains when on a bile acid sequestrant. They typically come in powders, so you need to take the patient to mix it in fluids that are not carbonated, and orally they should not cut, crush, or chew the tablet because it's meant to be broken down lower in the GI tract and not up in the mouth. They should take the drugs 1 hour before or 4 to 6 after any kind of diuretics, digoxin, warfarin, thyroid drugs, those kinds of drugs. It should not be mixed with other drugs to avoid absorption problems. The next class of drug are the statins. And atorvastatin is a commonly prescribed statin drug. It inhibits the HBG-CoA, causing a decrease in serum cholesterol, LDLs, and triglycerides, and thus increases the HDL levels in the blood, which are the good cholesterols. It is given as an adjunct to diet and exercise to treat high cholesterol and in LDL conditions, coronary artery disease, and after myocardial infarctions. Again, the adverse effects are typically GI with flatulence, abdominal pain, cramps, some nausea, vomiting, and constipation may occur. Patients may develop liver failure because of the way the drug acts in the liver. They may develop acute renal failure, have visual changes, and a very significant adverse reaction is rhabdomyolysis, and patients will have extreme muscle cramps with that condition. Statins work best when taken at bedtime in the evening. patients should regularly have their hepatic labs monitored. And you should use caution with these drugs, again, if they're used with warfarin or DIG. And estrogen levels may increase if taken with oral contraceptives. Statins should not be given with grapefruit juice because of the way the grapefruit juice and the statin reacts in the liver. So you need to teach your patients to avoid grapefruit juice on these drugs. It will take 2 to 4 weeks to see an effect from these medications. So typically, if the patient is started on a statin, they will be brought back into the office in about 4 weeks to have their liver levels drawn again, their cholesterol and hepatic labs drawn again, in order to see if the drug has been effective. Cholesterol absorption inhibitors work in the brush border of the small intestine to inhibit the absorption of cholesterol. Ezetimibe is the prototype in your textbook. It is given as an adjunct to statin therapy for patients with high cholesterol levels. Adverse effects include headache and dizziness, abdominal pain and diarrhea because it works in the GI tract, and patients may experience an increase in upper respiratory infections and have myalgias and arthralgia muscle pains. Use with caution in patients with liver disease, and warfarin levels may increase when combined with ezetimibe, so you need to check the warfarin levels more frequently. Again, as with all the other cholesterol medications, monitoring serum cholesterol and lipid levels is very important to evaluate the effectiveness of the drug therapy, and liver function studies should be monitored for toxic effects of the drugs on the liver. Please review the drug therapy across the lifespan for antiarrhythmic agents, the critical thinking scenario managing patients on chronic antiarrhythmic therapy, and the critical thinking scenario handling an angina attack to help you have a better perspective on caring for patients with these conditions while they're taking the drugs used to treat the conditions.